Hey guys, this is FixerMed. Welcome back to my high yield anatomy review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. This will be part 6 of a multi-part video series providing you with a broad overview of the entire discipline of anatomy for these examinations. So without further ado, let's go ahead and get started on today's content. First off, I'd like to start off by talking about Erb Duchenne Palsy. Erb Duchenne Palsy is a type of upper brachial palsy, which involves the paralysis of shoulder and arm muscles supplied by the C5 and C6 spinal nerves / roots of the upper trunk. This condition results from combined lesions of the axillary, suprascapular, and musculocutaneous nerves, which leads to the loss of function in the shoulder muscles and anterior arm. Clinically, patients with upper brachial palsy present with a distinctive waiter's tip hand posture characterized by an adducted shoulder, medially rotated arm, and extended elbow. Additionally, there is a loss of sensation in the lateral aspect of the upper limb, and you can see all of these conditions illustrated to the right on the illustration of the boy, where it shows the forward rotated shoulder, upper arm redness, muscle atrophy, and diminished arm length, and the waiter tip deformity of the wrist. Moving on to the next topic. Next, I'd like to talk about lower brachial palsy, also known as Klumpke Paralysis. Lower brachial palsy, also known as Klumpke Paralysis, is characterized by injury to the lower roots and trunk of the brachial plexus. This condition may occur when the upper limb experiences a sudden superior pull, leading to the stretching or tearing off of the inferior parts of the brachial plexus, specifically involving the C8 and T1 roots or the inferior trunk. Examples of situations causing this injury include grabbing support during a fall from a height, birth-related trauma, or as a result of thoracic outlet syndrome, also known as TOS. All intrinsic muscles of the hand are impacted as they are supplied by the C8 and T1 roots of the lower trunk. This involves combined lesions of the ulnar nerve, resulting in a characteristic claw hand, and the median nerve, leading to an appearance resembling an ape hand. Sensory loss is observed in the medial aspect of the upper limb and the medial 1.5 fingers, so the medial 1.5 fingers. Additionally, the condition may encompass Horner syndrome. Let's move on to the next topic. Injury to the musculocutaneous nerve. Damage to the musculocutaneous nerve typically arises from lesions affecting the lateral cord. This injury significantly diminishes the ability to flex the elbow, involving the biceps and brachialis muscles, and supinate the forearm, specifically impacting the biceps muscle. Additionally, there may be a concomitant loss of sensation over the lateral aspect of the forearm. You can see the illustration will show where the musculocutaneous nerve goes through and what muscles it affects. Let's go ahead and move on to some questions. So we have a 26-year-old man who presents with weakness in the shoulder and arm muscles, along with a distinctive hand posture characterized by an adducted shoulder, medially rotated arm, and extended elbow. There is also a noticeable loss of sensation in the lateral aspect of his upper limb. Which of the following nerves is primarily affected in this condition? All right, I think I gave you guys enough time. Moving on now, if you need more time, please feel free to pause the video. If not, moving on. This patient's clinical presentation is consistent with Erb Duchenne Palsy, also known as upper brachial palsy. The primary nerve affected in this condition is the axillary nerve, which is part of the brachial plexus and contributes to the innervation of the shoulder and anterior arm muscles. The distinctive waiter's tip hand posture is a result of the combined lesions of the axillary, suprascapular, and musculocutaneous nerves. This presentation is characterized by adducted shoulder, medially rotated arm, and extended elbow, along with a loss of sensation in the lateral aspect of the upper limb. Therefore, the correct answer here is C, axillary nerve. Let's go ahead and see why the other answer choices are incorrect. Radial nerve. The radial nerve primarily innervates the extensor muscles of the forearm and is not typically involved in Erb Duchenne Palsy. Ulnar nerve. The ulnar nerve is not a primary contributor to the muscles affected in Erb Duchenne Palsy, which primarily involves the axillary, suprascapular, and musculocutaneous nerves. Median nerve. The median nerve is not the primary nerve affected in Erb Duchenne Palsy. The condition involves the upper trunk of the brachial plexus and its branches. Musculocutaneous nerve. While the musculocutaneous nerve is affected in Erb Duchenne Palsy, it is not the primary nerve responsible for the distinctive hand posture and loss of sensation described. The axillary nerve plays a more central role in this presentation. Let's go ahead and move on to the next question. We have a 32-year-old woman who presents with a history of sudden superior pull to her upper limb during a fall from a height. She now exhibits a characteristic claw hand and ape hand appearance. There is a sensory loss in the medial aspect of the upper limb and the medial 1.5 fingers, 1.5 fingers. Additionally, the patient shows signs of Horner syndrome. Which of the following nerves is primarily affected in this condition? All right, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. The patient's clinical presentation is consistent with lower brachial palsy or Klumpke paralysis. The primary structure affected in this condition is the lower trunk of the brachial plexus, specifically involving the C8 and T1 roots. The combined lesions of the ulnar and median nerves result in the distinctive claw hand and ape hand appearances, respectively. Sensory loss in the medial aspect of the upper limb and the medial 1.5 fingers, medial 1.5 fingers, indicates the involvement of the C8 and T1 roots. Additionally, the presence of Horner syndrome suggests sympathetic pathway disruption from involvement of T1. Therefore, the correct answer is E, lower trunk of the brachial plexus. Let's go ahead and see why the other answer choices are incorrect. Radial nerve. The radial nerve is not primarily involved in lower brachial palsy. This condition affects the lower roots and trunk of the brachial plexus. Ulnar nerve. While the ulnar nerve is impacted in lower brachial palsy, it is not the primary structure affected. The condition primarily involves the lower trunk of the brachial plexus. Axillary nerve. The axillary nerve is not primarily involved in lower brachial palsy, which affects the lower roots and trunk of the brachial plexus. Median nerve. While the median nerve is impacted in lower brachial palsy, it is not the primary structure affected. The condition primarily involves the lower trunk of the brachial plexus. Let's go ahead and move on to our next question. We have a 28-year-old male that presents with weakness in flexing his elbow and supinating his forearm. He reports a notable decrease in sensation over the lateral aspect of his forearm. Physical examination reveals difficulty in performing tasks requiring elbow flexion and forearm supination. Which nerve is affected in this scenario? All right, I think I gave you guys enough time here. If not, be sure to pause the video. Otherwise, moving on now. The patient's symptoms are indicative of damage to the musculocutaneous nerve, primarily affected in this scenario. Lesions affecting the lateral cord where the musculocutaneous nerve originates results in weakness in elbow flexion. biceps and brachialis muscles, and supination of the forearm, biceps muscle. The musculocutaneous nerve also provides sensory innervation to the lateral aspect of the forearm, explaining the loss of sensation reported by the patient. Therefore, the correct answer here is E, musculocutaneous nerve. Let's go ahead and see why the other answer choices are incorrect. Radial nerve. The radial nerve primarily innervates the extensor muscles of the forearm and is not the primary nerve responsible for the described symptoms of weakened elbow flexion and supination. Ulnar nerve. The ulnar nerve is not primarily responsible for elbow flexion and forearm supination. It predominantly innervates the intrinsic muscles of the hand. Axillary nerve. The axillary nerve is not primarily responsible for the described symptoms. It innervates the deltoid muscle and is not involved in elbow flexion and forearm supination. Median nerve. While the median nerve contributes to forearm supination, it is not the primary nerve affected in this scenario. The musculocutaneous nerve originating from the lateral cord is more directly involved in the described symptoms. That will do it all for today's content in this video. If you have any questions, comments, or concerns, please feel free to leave them in the comment section below. If not, this is FixerMed signing off. Be sure to have a good day and happy studying, guys. Goodbye.